Oddly enough, the incidence, predictors, and prognostic impact of post-discharge bleeding after PCI with drug-eluting stents, it actually remains a little unclear. But some clarity is coming and was actually published in the Journal of the American College of Cardiology, September 2015, and I am here with an old friend of our program here. Well, I am with Philippe Genereux, who is an MD, Director of the Angiographic Core Laboratory at the Cardiovascular Research Foundation, CRF, and also an interventional cardiologist in Montreal, Canada. Now, this particular paper is from Jack, and you're studying the characteristics and the consequences of bleeding after PCI. First, why did you do this?
So that's a good question. Right now, there's a bundle of a burden of evidence that show that longer DAP, more potent DAP, may be better to reduce MI, stent thrombosis, and especially with the DAP trial and Pegasus, suggesting that to prolong DAP would be better for MI and stent thrombosis for patients, really for ischemic event. So there's a lot of data showing that. On the other hand, there's a trend and some meta-analysis also showing that bleeding may be more damageable, may hurt and may kill more. So the problem with all these studies that they are very biased. They enroll most of the time low-risk patients. They exclude patients from the get-go at high risk of bleeding or high risk of stent thrombosis. For example, the DAP trial, half of the patients were screened and were excluded. So we don't have a real snapshot or real evidence of what is the impact of bleeding versus MI in all-comers patients. So what we aim to do is to take the ADAPT-DES population, almost 9,000 patients, and to compare the incidence and the impact of bleeding compared to MI, but after discharge. So we remove all the peri-procedural events of bleeding, access related. We took only the successful procedure and patient alive at discharge. So day 3, day 4, and then we follow them up to 2 years. And then we look at the incidence of bleeding and the impact on mortality compared to MI or stent thrombosis. What we found was very striking, actually. It's probably one of the largest data sets to show that bleeding is way more frequent than stent thrombosis and MI, with around 6 to 7% up to 2 years after discharge. And it's kind of really severe bleeding that prompt the patient to go to the hospital or receive transfusion. So really 6 to 7% through time, increase very constantly through time. And the impact for mortality actually was threefold the one of stent thrombosis and MI. And when we put MI and stent thrombosis in a model to predict mortality with post-discharge bleeding, we show that clearly bleeding outweighed the impact of MI by threefold. So it really helped to put things in perspective in an all-comers population with the current DES generation that are safer than the first generation. Clearly state that bleeding kills more, bleeding is more frequent. So that's a piece of evidence that we have to put in the big puzzle of how long the DAP should be and for who, and then how potent. So I think this useful data that we can use to tailor antiplatelet therapy better. So I think that's important data.
So if you're considering DAP therapy, for example, what you might want to do is not only analyze bleeding risk, but once you recognize that there is a greater risk than maybe we appreciated, think twice before you go with a dual antiplatelet therapy beyond 1 year.
This is exactly what we try to show. So identify patients that are high risk of bleeding. I think now, unfortunately, the patients that are high risk for bleeding is always the same story, also high risk for stent thrombosis. They're sicker, older, they have atrial fibrillation, they have longer stent implanted, bifurcation, and so on and so on. So they are sicker, so more risk of stent thrombosis and an ischemic event, and high risk of bleeding. That being said, there's a bunch of data showing that stents are safe. Tullio Palmerini showed that, and we showed that multiple occasions that 3 months is probably okay. 6 months, 3 to 6 months of DAP is probably okay in most of the patients. Some patients deserve longer DAP. So the goal is really to customize, and like to your point, we need to identify the bleeder, and we need to identify the patient at high risk of stent thrombosis. And I think, for example, the study of BioFreedom presented at this TCT showed that it's possible with safe platform to reduce to 1 month and not compromise any other of the ischemic event, and reduce bleeding, or at least not impact too badly bleeding. Mm-hmm.
And that particular trial, they enrolled high bleeding risk patients.
Exactly, and it's very important because 30% of this study, you have triple antiplatelet therapy, AFib, so that's a real problem in common life. I mean, AFib is very common. Patients are getting older, sicker, so bleeding is a major concern. So you always have to balance both, and stent thrombosis and MI. This is a dramatic event, but bleeding also.
Oh, yeah.
I think we really need more data to see which patients should be receiving longer DAP, more potent DAP, and I think we're getting there. To customize the antiplatelet therapy. So this data is one piece to the puzzle. Doesn't solve everything. There's some limitation, obviously, to this publication, but at least is one that with strong argument to say, take it easy. Don't give 1 year, 3 years to everyone, because patient will come back. So I think it's reinforced the fact that you need to follow patient. To reassess at 3 months, 6 months. How are you doing? Do you bleed? And to do this kind of dynamic follow-up with the patient and evaluation, because the risk can change also through time.
I've been reading criticisms recently that none of the bleeding hazard risk algorithms are particularly effective. Have you found that, or is it more of a back of the napkin type of thing, or is there one that you think is better than the other in terms of trying to predict which one of your patients is going to have a higher bleeding risk?
No, you're right. When you look at, for example, the well-known CHAS-VASc2 or ASH-BLED, I mean, they barely have all the same variable. So you have a high ASH-BLED, you're going to have a high CHAS-VASc. So this is mainly a marker of sickness, and we try to handle the situation the best we can. So no, to your point, we don't have the perfect algorithm. I think now we're at a point where if you're high risk of bleeding or high risk of stent thrombosis, you need to put everything together. Platelet reactivity, patient characteristic. This is on this patient, and use safe platform. So, of course, not use BMS. This is almost an obsolete technology, but be careful with what platform you use, and tailor your antiplatelet therapy accordingly. So we are there. We're getting we're doing great progress with safer platform.
Yes.
And then now we just have to tailor the intensity and the length. So we're getting there.
Well, it's Philippe Genereux and colleagues. Please go back to the September issue of JACC and pull this one out. It is on the incidence, predictors, and impact of post-discharge bleeding after percutaneous coronary intervention for Cardiosource World News. I'm Executive Editor Rick McGinn.